Thanks, Henry, for joining me. Today, we're going to talk about supporting next generation HIV prevention options, leveraging JSI's experience in new product introduction. In terms of HIV prevention, we recognize that the HIV field requires innovations, new players and ideas which must utilize evidence-based programming, absorptive capacity, and sustainability. Existing prevention methods have clearly not done enough to stop the spread of HIV among key and priority populations. So we are looking at new prevention options, and JSI is committed to rolling these out, including new delivery mechanisms, such as biomedical prevention, injectable PrEP, and the dapivirine vaginal ring, which are currently progressing through regulatory approval. And as you'll talk a little bit about expansion of oral PrEP in Ghana, I think we can use that as an important platform for the introduction of these new biomedical prevention interventions. So I'm glad to speak with you today. This is Dr. Henry Nagai. I'll let him introduce himself, but real quickly, my name is Sean Maher. I'm a senior HIV advisor with JSI's HIV and Infectious Disease Center. So first off, Henry, thanks for joining me. And if you would, a brief introduction about yourself and your work in Ghana.
Thank you very much, Sean. It's a pleasure talking to you and, discussing this very important topic. My name is Henry Nagai. I'm a medical doctor and chief of party at JSI. I supervise the USAID Strengthening the Care Continuum project, which provides comprehensive HIV treatment, care, and preventive services in 3 regions in Ghana, including a focus on key populations in those regions. I'm very happy to talk to you this afternoon.
Super. So let's start off talking through your experience in Ghana supporting the introduction of PrEP. Can you just tell us a little bit about where you started, who the stakeholders are, how they were engaged, and how it's going today?
This is a very important story that can be written in various forms and shades, but it started out of a key a realization, an observation I made during a visit to one of the regional hospitals in Accra, the Greater Accra Regional Hospital, to be specific, the Ridge Hospital, where I sat in to provide mentoring and coaching services to a senior nurse who is a director of nursing services, but she has been trained to be HIV service, competent, and she was providing services. And she has a number of men who have sex with men from allied communities of the hospital who come to her to receive services. So during my support to provide treatment and care services, one of the sessions was such that a client asked me that he heard about pre-exposure prophylaxis, and all that he read was from studies in East and Southern Africa, and wants to know whether PrEP is available in Ghana. And then he also said that, well, when he looked through the drugs that are being used, he saw that we have tenofovir and we have lamivudine. And as an MSM, he thinks that we should be able to provide him with the tablets to start PrEP, because he read from the literature that this is very, very good preventive tool to have. And then at that point, it just struck me that, we need to do something to make sure that PrEP, first of all, becomes a policy that has been adopted and approved by the Ministry of Health, the Ghana Health Service. Second, to ensure that it actually gets into the interventions, minimum packages that the country can implement. And so once it was a research agenda that has been approved and they were part of the approval process, it was easy to get them on board. So both the Ghana Health Service and the Ghana AIDS Commission accepted that we should go ahead with the feasibility and acceptability studies. And so we developed the protocols and went through the IRB of the Ghana Health Service to have the protocols as accepted and to allow us to implement, the acceptability and feasibility study. I must mention that the protocol came with a caveat, and that caveat is very, very important in terms of our experience, and that is that was such that we should include a clause that will require the study team to enable any of the key population member of the key population community who decides to receive PrEP as a result of understanding the study to actually benefit from PrEP. So we went through the process, and the results of this feasibility acceptability study, it was outstanding. The first thing is that we have relatively high level of acceptance among key populations. We also found out some of the inhibitory factors that service providers have in terms of the myths about PrEP and what their concern was in terms of PrEP introduction, and they were generally bordering on availability of ARVs for general population and treatment, let alone we having a program that would use the scarce resources of ARVs for preventive activities. The second was also to do with fear of transmission of resistance. At the time, the evidence in terms of resistance was just beginning to build, that you don't have a lot of resistance as we think was going to occur if two molecules are being used for preventive activities. And then the other concern for policymakers was, how exactly we're going to receive it. And there were a number of issues relating to, even distribution and, regulatory approval, whether we're going to have Truvada, as it were, that is tenofovir and triticizoline, as the combo that is known to be available, and whether we can be allowed to use tenofovir and triticizoline, issues about costing and modeling. So we have the policy level cleared. Now, when it came to implementation, there was a lot of discussions. So we had to support the development of various tools and other items for data collection and how clients will be followed up on. We've discussed this with USAID, but as usual, the Ghana Health Service have to go through processes because it requires getting more medications, getting more tenofovir and triticizoline, that is, a combination Truvada, and then also ensuring that we have to have commodity security to make sure what quantities will be required, what are the beneficial populations, etc. The National AIDS Control Program mandated us to focus not only on key populations, but also on serodiscordant couples, and also on men and boys, and anybody else that would want to benefit from PrEP. So we started that in the Western region, and we started with about 6 health facilities. Now, what we did was to make sure that we have the health facilities leading this process, because it's biomedical intervention. It is a biomedical service that we are providing, and the facility level is such that clients need to get their drugs from that level based on the model of service provision that exists in the region. So we started from the 6, and we gradually scaled up to over 20 sites as we currently have. I must say that I happened to take a decision, two key decisions. One of them was that that we are going to implement PrEP under an implementation science approach. This is to make sure that in terms of implementation, it is relatively new, and we want to be learning as we are going and plow back these learning to improve the program. So we need to have some scientific data collection and other things as part of the process. So we carved it in an implementation science mode so that we can be actively use information to improve what we were doing. Secondly, is that we should go slowly because of the kind of barriers that we faced and the kind of uncertainty that a lot of service providers and policymakers had. We decided that let's go slowly. So we started with actually centralizing the services. So instead of decentralizing straight away, as you would do for a matured intervention that is known in the country, we started rather to centralize it. So we didn't decentralize to begin with and having it everywhere, including sub-districts in the geographic region. We didn't do that. We centralized it, selected specific health facilities, about 6 of them, making sure that they can be it can be done and done well, and we know how culturally the feedback and the thinking around it and how we're going to monitor those who seroconvert and ensure that everything, including the commodity security and accounting for commodities, will all be in place before we can scale up. So we centralized, and then we started scale up in selected manner as we go along. And then also, one of the lessons that we have learned is that community PrEP is key. So as a result of starting at the facilities, we expanded community outreach, PrEP outreach, where we have civil society organizations that have competency, knowledge to be able to enter into the networks of key populations at community level, where we have the female sex workers communities and their brothels and their what we call CITES communities. So community pre-exposure prophylaxis outreach is currently active and ongoing, serving identified sex worker communities in the region. We realized that when we added this component on it, our coverage increased exponentially. And one of the things that we did was, as I said, we decided to go slowly before we started advertising and getting more and more people to know that pre-exposure prophylaxis is available and it can be accessed from various areas as we have it. So currently we have health facility led and directed pre-exposure outreach that is ongoing. And it has been very successful. And we know that there's the support of the health facilities in leading this at the community level in collaboration with the civil society organizations has been a great advantage for us, because the refill mechanisms are driven by the health facilities who are serving the outreach communities for PrEP. I will end by saying, and if there are any questions, I can answer them by saying that a key lesson we have learned in Ghana in the care continuum program is this, that it is erroneous to think that you can implement HIV pre-exposure prophylaxis program or services by riding it on existing programs. We realize that it doesn't quite work that way. And so we change along the line to make sure that we can be able to budget clearly for PrEP services and ensure that we can laser focus and be very purposeful on it as an integrated, but a service that requires to be funded to be successful. The initial thinking was that we will just overlay it on the existing programs and it's going to just run like any of the services. But we realize that in our context, it is not like that. It requires some support to enable it to work, especially when it comes to focus on the community outreach for PrEP to the beneficiary population. So I'll end here, and if you have any questions, I will be ready to respond to them.
Sure.
Thank you.
Thanks, Henry. That's a really long journey that you took us on. And I remember starting some of those protocols on the feasibility study as early as 2016. So I appreciate the length and the detail of this process. In fact, while you were speaking, I was reminded of the ICASA panel that you and I co-presented on in Abidjan in 2017. And
Correct.
I remarked after that, the Ghanaian delegation made up of members of the AIDS Commission and the Ghana Health Services. The only question that I was asked repeatedly was my personal story. I started the talk by saying that I've been taking PrEP since 2014, and most of the questions had to do with how it made me feel, the pill burden, side effects, etc. And so that really struck me in the personal connection. How important that is, and the personal story. And you do mention the community involvement, which I think is key. And I know from the feasibility study we did, we pulled in aspects of human-centered design or human-centered design light, as it were, and how critical those are. And so I guess my question is twofold. It's how do we incorporate more of that, either behavioral economics or human-centered design in learning how to roll out future biomedical HIV prevention products. And then to your last point, mentioning your key lesson is that, PrEP could not ride on previous programs and how much had to go into its unique development and support. I want to know, how can we learn from what we did? We don't want to reinvent the wheel. If the ring comes out or injectable PrEP, should be right behind it, or, other sort of products, how do we take what we've learned and not have a 4-year runway in order to get those products approved? So if you could just briefly talk a little bit about the engagement of the community, looking forward to new products, and then how we can take what we've learned to accelerate new product introduction in Ghana.
Yes, thank you. My response to the first one is that it is critical to involve members of the beneficiary communities. It is very, it's almost like that is the chip that fixes everything. And the human-centered design component right from the beginning in terms of their involvement in the protocol development and what their deep understanding and their needs are in terms of fashioning out the implementation was very important. And I think that cannot be overemphasized. I think that every program where you have new biomedical intervention, especially biomedical intervention, it will require that the beneficiary populations are clearly identified in their different arrangements and supported to participate in the process. This was very useful for us when we got to the point where we have strengthened the facilities and we decided that, okay, let's now gradually open the floodgates by making known the availability of PrEP services through the community radios that targets the beneficiary populations that we know have expressed the need and saying during the study that they are going to uptake a PrEP. Once that was done, it was very easy. So you can see the various trends that we have. Everybody asks us, what did you do to see this exponential rise in your coverage? And simply put, it is because of the human-centered design approach and involvement of the communities and their expectations and their understanding that made it easy to get the services to them. So that is key. The other thing I must say about the delay in terms of the process, I think that introducing everything there are different aspects of it. In my view, one of the things that have delayed the process in Ghana in terms of adopting PrEP as a policy and getting implementation underway, my personal view has been that this is as a result of low level of participation of the scientific community in Ghana, including staffs of the AIDS control bodies in Ghana, low level of participation in some of the research activities that have led to the introduction of these new biomedical products. For example, PrEP. Unlike probably East and Southern Africa, where a lot of biomedical prevention studies started, some of them went to completion and have gone on to products that have been introduced. Relatively in West Africa, and particularly in Ghana, we've not had a lot recently in terms of these activities. And therefore, when you have these products now to be introduced, and you come into the area of introduction in Ghana, it means that you have to take a lot of, takes a lot of effort and time to get the scientific community and build consensus on it and be able to provide a lot of information to get everybody on board and to support the decision-making at the regulatory authority and then the age control authorities level to make sure that we can get approval for interventions to take place in terms of services to take place. So I hope that the new products that we have, having learned from these experiences in terms of introduction, we're going to do better than what has happened to PrEP. What it means is that, yes, the products are already in place for use, but in terms of supporting the advocacy and be able to get consensus at the technical working groups and moving through the regulatory levels, even including the costing and modeling, we have the experience. And that experience will be hugely useful for introduction of other, long-acting cabotegravir as a prevention or treatment, or the pivirine ring introduction. And I am hopeful that we'll not go through that long period before we see it getting into the hands of the population that needs it most.
Great. Well, switching gears for a moment, I know you were a contributor to the Adaptable Product Introduction Framework for Biomedical HIV Prevention. And from my read of it, it's an excellent tool. Can you give us an overview of the framework and just a little bit more background on it, on its purpose and audience?
Yes, so this has been as you know, has been a global effort. It took a long time, and there were different groups to look at different areas. So it's a framework that looks at different stakeholders and how we can think through these different stakeholders, and more importantly, the stakes that they have as key stakeholders in the process, and how countries can make use of the framework in navigating the inputs and the dependencies, as we call it, as you go through the framework. So it is a tool, and it looks at matters that borders on, for example, the distribution, manufacturing and distribution. So when you take your country as, and within the concept of globally, manufacturing and distribution, it also looks at the regulatory approval processes. What you can do, different countries have different regulatory bureaucracies and governance of regulatory decision making, etc. So it talks about how you can go through that. If there's need for some clinical research at country level or with bioequivalence research, etc., etc. It looks at aspects like that, and also the delivery and implementation, which is very key, and what one can do in terms of best practices and involvement. Very important, because if the beneficiary population are not involved, they don't know about the product and they don't know what exactly it entails, then introducing a biomedical prevention intervention becomes a problem. Then the costing and the modeling. As you know, the same product can cost, the cost for the same product is different depending on the country and the sub-region and across the globe. Something that costs maybe $20 in the US may cost $5 in Ghana because of some disparities, and sometimes because it is a program and you get part of the cost absorbed, or issues to do with branding and generics, and sometimes how how advocacy and how to talk through pharmaceutical groups and advocates in various countries to look at the modeling and the costing. And then, continuous use, because individual uptake is very important. For example, when you look at PrEP, there has been a lot of modification in terms of how to increase coverage and uptake. And we've learned a lot from some of the mistakes, if you like, of the introduction of PrEP and how that can be done. So all these things have been factored into the framework. In fact, it took a lot of different people, to look at the different areas, and even this include how I would say stakeholders and their stakes, and how one can coordinate this at country level. And so the framework, I would say that it is a very important document that has come out. It looks at different areas, what you can do, for example, before you push for regulatory approval at country level. It also talks about what you can do. I remember we had a long argument about implementation, and we have to review that area over and over again to take care of different feedback that we have had, and especially for the area of key populations and their sexual partners, how all that will play into it when it comes to introduction of other preventive preventive tools. So there's a lot in getting this. For example, there is a module that is my favorite, which is the what we call the COGS, conduct of COGS analysis. COGS is the cost of goods analysis for low and middle income countries and contexts, because you need to be able to estimate various associated costs. The costs that are associated with introduction in Ghana, because of our peculiar context, will be different from what you think of in the US, for example. There are some preventive products or interventions where it's a matter of cost in the US, and nobody thinks a lot about the costs associated with it. Once it is something that can save life, that will enable someone to receive treatment if it is positive, that goes ahead. Once it can prevent disease, it can go ahead. In our context, there's a lot of economic questions that are asked. So you have to look at all this is considering various parts of the associated costs, raw materials, labor, and other overhead costs associated with the product, including the profit margins for developing countries and that of advanced or developed countries, which can be different, as you know. So yeah, that's what I can say, with these two, and I think I think we will see how it performs. But it's a good product that I think will be very helpful in fast tracking, if you like, the introduction of new biomedical products.
You're right. The document asks a lot of important questions, helps identify linkages and potential areas for future work. It's both highly conceptual and very granular at the same time. So I found it very useful, and you can tell that there's a lot of thought leaders contributing to it, both lessons that we've learned from oral PrEP and mistakes, like you noted. The 5 categories that it's divided into are manufacturing and distribution, clinical research and regulatory approval, costing and modeling, delivery and implementation, and individual uptake and continued use. So all super important areas. And then it's, like I said, as granular as identifying critical pathways and enabling activities for the user. So hopefully these new biomedical prevention products will ease into the market a little bit easier than PrEP did. Well, Henry,
hopefully.
And we'll make sure that this document is hyperlinked to our website so people listening to this interview can access it as well. In addition to the many excellent materials supporting PrEP rollout that JSI has designed, including communication roadmaps and SBC tools, we have all of those on our HIV materials link on the JSI website. So Henry, we're getting to the end of our time, and I really appreciate your time and your candor, the thoughtfulness of your responses. Anything else you'd like to add when thinking of either advice or lessons to those that will soon hopefully be implementing new product rollout?
Yeah, thanks, Sean. I think one key thing is for me to see in Ghana when we have Kabele or the preferring ring available, and the woman can walk into any of the over-the-counter medical or pharmacy and get that and be able to have the choice to get him or herself, prevented from acquisition of HIV infection. I think that we should all continue to advocate and push that these products will become available and will be widely in use to move our epidemic control effort forward going into the future. I think that if we would achieve the targets for 2030, these new tools in the prevention arena would be important, would be key to provide the choice that is needed by those who most need to make a choice to prevent themselves from getting HIV. Thank you.
Thanks very much, Henry. I wish you luck in your continued PrEP rollout, and thanks again for taking the time to speak with me.
Thank you. It's a pleasure, Sean, and look forward to good things in the couple of months coming. Bye-bye.